Okay, right. Right, so let's crack on with the respiratory system MCQs. So this is MCQ set 2, okay, which is focused mostly on infections of the respiratory system. Starting the okay. Right, now let's start with pneumonia. And this is just a quick revision of the concepts of concepts in pneumonia. Now, as you all know, pneumonia is classified on a clinical basis. Okay, so you have a clinical classification for pneumonia. And this clinical classification is based on the setting in which the pneumonia occurs in. Okay, the setting in which the pneumonia occurs in. And as you can see, there are 4 main types of pneumonia, right? You have the community-acquired pneumonia, hospital-acquired pneumonia, which is defined as you have to get the pneumonia sort of after 48 hours after hospital admission. Then you have aspiration pneumonia, immunocompromised, so pneumonia that occurs in the immunocompromised setting. So these are the main 4 groups of pneumonia. And as you can see, this clinical classification enables us or gives us the opportunity to guess the organism also. And I have listed here the common organisms in each clinical type. Right now, the good example is community-acquired pneumonia. It's mostly due to strep pneumonia, right? But if you take hospital-acquired pneumonia, you see more gram-negative related organisms like enterobacteria, pseudomonas, and sometimes things like Staph aureus also, right? Aspiration pneumonia is different. Again, gram-negatives, anaerobes from your gut are the causes there, right? And then you have the pneumonia in the immunocompromised patient, which is a whole different set of organisms, like pneumocystis, for example. Okay, so this clinical classification allows you to guess the organism also. මේ all MCQ වලට වැදගත් මම කියන්නේ මේ slide එකේ විභාගයට යන්න කලින් බලාගෙන යන්න. Okay, right. Now, true or false regarding community-acquired pneumonia. So a little bit more MCQs on etiologies here, right? Strep pneumonia is the commonest bacterial cause of community-acquired pneumonia is right. That is correct. The numbers are going down now because people are getting vaccines against strep pneumonia, but still it is the commonest. Then මේක ඇහුවොත් පොඩ්ඩක් bacterial නිසා ප්‍රශ්නයක් නැහැ. Things like COVID also come into the picture. Hari? Okay. Hari. Now going to COVID ගැන කියලා දීලා තියෙනවා when you had your clinical emergencies, but මෙතනම MCQ දාලා නැහැ, but we will talk about it when we do other papers and stuff. Right? Okay. Now the fact patients with chronic lung disease and chronic cardiopulmonary disease, one of the important organisms is Haemophilus influenzae. Right? So especially patients with chronic lung disease are famous to get a Haemophilus infection. Apart from that, the other famous fellow is Pseudomonas. So patients with chronic lung disease, you see quite a lot of Haemophilus and Pseudomonal infections. Right? So people with COPD, interstitial lung disease, in those sort of people, Haemophilus and Pseudomonas are quite important causes of pneumonia. Hari. I will leave the third one for the moment. Fourth one, E. coli is a common cause of community-acquired pneumonia is absolutely false. E. coli does cause pneumonia, but that is mostly hospital-acquired patients. Hari. Mostly in the hospital-acquired setting. Hospital-acquired setting. Okay. Staph aureus is known to cause pneumonia in patients with influenza A infection. This is well known, right? So post-influenza pneumonia, Staph aureus is an important cause. And we have seen this after COVID also, right? So after COVID also, you can get these secondary bacterial infections due to Staph aureus. And that's quite a nasty pneumonia that they get. All right. So this is just a bit of etiology based MCQ, right? About pneumonia. Remember, lung disease, Pseudomonas, Haemophilus, chronic lung disease. Those are the 2 important organisms. So I have given you again here a list of organisms again to bring out the important fellows here. මේවා නිකන් බලාගන්න MCQ වලට යන්න කලින් sort of related to so alcohol alcoholism තියෙන අයගේ aspiration pneumonia the set is different හරි and I have given you here chronic lung disease structural lung disease තියෙන අයගේ the organisms are quite different from the usual fellows. Okay. Now this is an important table or whatever figure that gives you causes of cavitatory pneumonias. Causes of cavitatory pneumonias. Method causes of cavitatory pneumonias. Now I have seen MCQs in the past where we ask you, right, what of the following are causes of cavitation in an X-ray? එහෙම අහන වෙලාවල් තියෙනවා. ඒතකොට infection විතරක් නෙවෙයි තව જાතිත් තියෙනවානේ. Malignancy, rheumatology, I've given you the whole list here. But for today, we'll focus on the infections causing lung cavitation. Lung cavitation. So, ඒක හොඳට බලා ගන්න ළමයි මේක MCQ වලට අහන 1 2 3 4 5 what are the causes of cavitatory pneumonias කියලා වගේ MCQs තියෙනවා. හරි? In these banks of MCQs there are MCQs like that also, right? So that's important to remember that there are certain causes of cavitatory pneumonia. The famous ones to remember are Staph aureus. බොහොම වැදගත්. If you remember 2 of this list, that's fine. Staph aureus is a very famous organism that causes a cavitatory pneumonia. The other fellow is Klebsiella, right? Klebsiella is another famous cause of cavitatory pneumonias. තව රෙයායව තියෙනවා මේ nocardia නම් මනම් ඒවා කලාතුරකින් දකින්න දේවල්. But for if you take bacteria, the ones that you see often are Staph aureus pneumonia and Klebsiella, which causes lung cavitation. Lung cavitation. එතකොට MCQ එකේ ඕක තමයි අහන්නේ ළමයි. හරි? නේද? Klebsiella is associated with pulmonary cavitation නේද තියෙන්නේ. හරි. But remember there is a whole list of organisms that cause lung cavitation. Infection with lung cavitation. So මේකත් බොහොම වැදගත් slide එකක් MCQ වලට. Now the next MCQ is based on the difference between typical and atypical pneumonia. Now this typical atypical pneumonia kira concept is slightly outdated but still used. And in MCQs you will encounter this terminology. Now I'll come back to this MCQ. In the next slide I have given you a summary of the differences between typical pneumonia and atypical pneumonia. Now, the main reason why typical is called typical and atypical is called atypical is, remember, this is not because of the organism, right? Oka pandu kasa hema ogollo kiwuwot ema hari asa weyi because nobody answers the question properly when he asks this. The typical atypical classification is not based on the organism. It is actually based on the pathology that occurs in the lung. That is, it is based on the pathology that occurs in the lung. So a typical pneumonia, you get mainly a lobar or alveolar consolidation. Alveolar consolidation. Alveolar consolidation. So in that alveolar consolidation, you get exudate within the alveoli, right? Within the alveoli, right? And the famous organism is strep pneumonia, right? So there is exudate in the alveoli. Consolidation within the alveoli. In atypical pneumonia, the consolidation is in the interstitial space, right? The inflammation is in the interstitial space. And the common organisms that cause atypical pneumonia, fellows like Legionella and Mycoplasma, where the inflammation is in the interstitial space of the lung. Whereas in a typical pneumonia, the inflammation and the exudate is all in the alveolar compartment, all in the alveolar compartment. Then in atypical pneumonia, apart from this difference, they can have a difference in the clinical profile. And remember, there are a whole lot of odd, unusual extrapulmonary manifestations of atypical pneumonia. Extrapulmonary manifestations. Things like hemolytic anemia, right? Some neurological syndromes. These are all unusual extrapulmonary manifestations of the in atypical pneumonia related to Legionella, Mycoplasma. Right. Now, also in atypical pneumonias, you won't get the very classical full-blown inflammatory profile in the investigations also. If you have a strep pneumonia, you get high neutrophil count, white cell count, CRP will be sky high, right? And you can isolate these organisms very nicely. But in these mycoplasma, Legionella, you don't get that pattern. You don't get that pattern, right? You don't get that very typical neutrophil leukocytosis or the very high CRP, right? So remember that. Okay, so in the lab also there will be a difference between these organisms when you look at it. Radiologically, because typical pneumonia is alveolar consolidation, you will see the alveolar consolidation on the X-ray also. And sometimes you can see that confined to a lobe. Right. In atypical, you will see the interstitial sort of shadowing. Typical pneumonia, alveolar shadowing. In the atypical pneumonia, it's mostly interstitial shadowing. And it's everywhere. Patchy, extensive. And also, this is something that we like to say, the physical signs are minimal. When you examine the patient, the physical signs are minimal. But the chest X-ray ke khana palenna thiyena. Right? So chest X-ray is full of extensive patchy disease. But when you examine the patient, minimal physical signs. Minimal physical signs. Right? And also the treatment is different because of the organism, obviously. Right? So these are the sort of differences between typical and atypical pneumonia. But remember, the fundamental difference, Lamai, is that in atypical pneumonia, it is more of an interstitial inflammation that occurs. Whereas in a typical pneumonia, it is the more lobar, so alveolar consolidation that occurs. This is the main difference. But there are obviously other differences as well. Right. Now, MCQ, keeping this in mind, let's go back to the MCQ. True or false regarding atypical pneumonia? So remember, the fundamental difference is the interstitial versus alveolar inflammation. Atypical pneumonia can be due to infection with Legionella. Yes, we know that. Legionella, mycoplasma. Another fellow is chlamydia, right? Chlamydia pneumoniae, chlamydia psittaci. Those psittacosis, it's sort of from parrots. Chlamydia psittaci. Prominent physical signs with minimal, atypical pneumonia, prominent physical signs with minimal infiltrates on the chest X. So in atypical pneumonia, there is interstitial inflammation. So the interstitium is everywhere and you find a lot of extensive patchy lesions on the X-ray and the CT if you do a CT. Right? And the physical signs are minimal. Physical signs are minimal. So this statement should be the other way around. So this is false. Neutrophil leukocytosis is a frequent finding. In atypical pneumonia, you don't get that full-blown inflammation response. Full-blown inflammation response. Typical yes, pneumonia WBC count will be very, very high. CRP will be very, very high. But when you get a mycoplasma sort of fellow, it's a completely different picture, right? And as you know, in atypical pneumonia, you cannot culture these organisms. You need various other ways of diagnosing these organisms. And penicillins are not the first line drugs. We commonly use things like macrolides and doxycycline for atypical pneumonia. So write those down. Macrolides like azithromycin, clarithromycin, and doxycycline is another thing that is used. Doxycycline. Right. Okay. So just get this into your head. There is a very high probability that you might get an MCQ on this concept, right? On this concept. Or even an SCQ focusing on this sort of thing. Right. Okay. So this is the very typical sort of appearance of a typical pneumonia, lobar consolidation, whereas atypical pneumonia on the right would be more of a sort of patchy thing. Patchy, you can see it's right, sort of patchy infiltrates everywhere. CT ke karamo kohondra peno. Now, it is very common to find when you go to the past papers, obviously, we love to ask about Legionella pneumonia. Again, I have no knowledge of what sort of questions you'll get this time. And if I had a knowledge, I could have taught you like this. But this is a very sort of famous thing among examiners to ask an MCQ about Legionella. Legionella, there are certain risk factors that are common, like sort of it's common in smokers and people with chronic lung disease. And the very classical way it spreads is ogolo make a microbiological make a matakai. This is something that you remember, that Legionella are AC systems, right? So it's contaminated aerosols. It's in the water, and when in AC systems, so officers, hotels, that sort of thing, you see this. Hari? Hari? So hotels, AC systems. So make a best response MCQ එකක් දෙන්න පුළුවන්. ඒතර මූ රට ගිහිල්ලා මොකක් හරි හොටෙල් එකක ඉඳලා නියුමෝනියා හැදෙන, that sort of story is probably Legionella. Legionella. And it can have a spectrum of manifestations. One of the important things to remember here is that hyponatremia is very common in Legionella. Hyponatremia. Very, very common. Hyponatremia is very, very common in Legionella infection. And the mechanism is probably an SIADH related mechanism. Right? SIADH related mechanism. Now, as I have told you before, Legionella diagnose karanna, you can't culture the fellow. You can't stain the fellow. You need to do what you call a Legionella urinary antigen. That is how you diagnose. Legionella urinary antigen. So remember that. You can't culture sputum or whatever, you can't do any of that. You have to do a Legionella urinary antigen. So ගැන විතර අපි කැමති අහන්න. මෙතන ලොකු ලිස්ට් එකක් තියෙනවා මේ Legionella වල various unusual manifestations, right? මේවා පස්සේ කියව ගන්න එනවා දිස්සියන්නේ. Right. Okay. Any questions up to now? So another MCQ. So I'll do the first two things first. So already we've learned that hyponatremia is a common feature of Legionella infection. That is important. Very common. This is very often. Right. Now, anitaka mycoplasma. Legionella වගේම mycoplasma ගැනත් අපි අහන්න කැමති. We like to ask about mycoplasma also. The key thing to remember about mycoplasma is there cold hemolytic anemia is a common association. Right? Cold autoimmune hemolytic anemia. The cold agglutination, cold autoimmune hemolytic anemia is something that you see very commonly in mycoplasma infection. Okay, so those are so all these questions are sort of based on etiology, typical, atypical pneumonia, nammanan kadanda. Okay. So cavitation does not always include lung abscess. The cavitation without lung abscess is not puluang children. You can get called cavitation without lung abscesses, right? Also, but actually most cavitation leads to a lung abscess, but you can get just cavitation also without lung abscess. Okay, fine. Okay, now let's go on to the sort of complications of pneumonia and the sort of risk stratification of pneumonia. Good, right? I'll talk about the pleural effusions later, but now these are important. Now, when you have a pneumonia, when you're managing the pneumonia, you have to be able to risk stratify the pneumonia. Risk stratification. Now, the famous risk stratification, which you have to know by heart, is the curve 65. Make අනිවාර්යෙන් දැනගන්න. මේක ගැනම MCQ අහලා තියෙනවා. And also, it's very easy for us to set an MCQ giving you a clinical scenario of pneumonia with information which we can give you for the curve 65 criteria, and then ask you what should be done. So in this figure on the left, I have given you the curve 65 criteria plus the what do you do with various curve scores? Mortality and what you do. So if the curve score is above 3, you have to, there is a very high mortality and you have to admit, and that is severe. So the curve 65, apart from giving you a mortality estimate, it also tells you whether the patient needs to be admitted or not also, right? So if the curve 65 is 0 or 1, home treatment, oral antibiotics. It gives you that information as well. Right? The curve 65 that you have to know by heart. So these are when you're managing pneumonia risk stratification tools. Then Babu, make also is something that we use. Make a thing you can't remember katapadamin, but go through this and sometimes MCQ or end these various variables. So this is called the pneumonia severity index, right? And there are 4 domains in the pneumonia severity index. Right? So age, other comorbidities, signs on the physical examination, which some of them overlap with the curve 65. And also laboratory and imaging domain. Right? So if you have hyponatremia, you get a certain score. If your blood urea is off, you get a score. So that is also in that kata. In that kata. So pneumonia severity index, curve 65, are all measures of severity, and decisions on management have to be taken. Right. This is another one, which again you have to be slightly familiar with, right? This is when you decide. So the නිකන් scoring system ටිකේ නම් ටික පොඩ්ඩක් මතක තියාගෙන කල ඇහැට හුරු කරගන්න. ඇහැට හුරු කරගන්න. හරි? ඒතර ඇහැට හුරු කර මේවා කටපාඩමින් දැනගන්න ඕනේ. Curve 65 you have to know. But these concepts in the pneumonia severity index, we can easily make an MCQ. What of the following indicate more severe pneumonia? ඕන බුරුවෙට්ට ඔය වගේ MCQ එකක් හදත හැකි. Right? So then you have to be familiar with what sort of thing, most of it is common sense. What sort of thing comes into that කියන එක. Right? Okay. Now, as you know, a subset of patients with pneumonia have very, very severe disease. And this is the spectrum, very severe pneumonias that need ICU admission. Right? So, in this, certain things you need to remember. Right? All of this is common sense, right? Common sense, except for, not except නෙවෙයි. මෙන්න මේ leukopenia කියන එක මතක තියාගන්න. That is very important. Okay, MCQ වල අහන දෙයක්. Now, you would obviously think that higher the white cell count, the more inflammation there is. But actually, if the white cell count is low, that means there's something drastically wrong. You have a pneumonia with a very low white cell count. That means that's something drastically wrong, right? And that is the patient that I'll be more worried about. That's a pneumonia. Chest X-ray, multi-lobe infiltrates, right? Then very ill patient, but the white cell count is about 2,000, 3,000. Now I know metana Haryana potak neve kiela. So actually a lower white cell count sometimes is more troubling to us, right? It occurs frequently in elderly people who can't mount a good inflammatory response and they can't clear the infection off. So low white count is an important thing to remember. The rest of it is common sense. So may score එකක් තියෙනවා මෙතන. හරි? More than 3 require ICU admission, right? More than 3. Hurry. So this is just to make you familiar with some of the prognostic scores and the risk stratification scores for pneumonia. Hurry. Right. So මෙතන ඕක තියෙනවා arterial pH less than 7.2. Yes, indicates a poor prognosis. ඒක තිබ්බ මෙතන arterial pH value එක දීලා තිබෙන්නේ නැති වුණාට sorry, not in this. When the method arterial pH, if it's acidosis, it's whatever dangerous, right? Acidosis. And then leukopenia is predictive of ICU admission. Need of ICU admission. Yes. Okay. Hi. Any questions? Okay, right. All right, now this is best response MCQ number 1. ඕකේ තියෙන කතාව තමයි bacterial pneumonia following influenza මනම් කතන්දර තියෙනවා, and there is a pleural effusion on the right. There is a pleural effusion on the right. So patient has initially improved but now worsened. ඒක තමයි උතන කතාව තියෙන්නේ. Right, and now there is a pleural effusion on the right. So you can see in the investigations that the white count is increased and there is a pleural effusion. CRP එක දීලා නැහැ, but the white count is increased. දැන් මොකද්ද මේ තියෙන්නේ? What is the diagnosis first? What is the diagnosis first? Now this brings us to the topic of pleural effusions in pneumonia. Right? Pleural effusions in pneumonia. Now, pleural effusions in pneumonia, pleural effusions following pneumonia. Because pleural effusions during pneumonia is not very when you have pleural effusion after pneumonia or pleural effusion isla pneumonia pleural effusion you are a little worried, and these are called parapneumonic effusions. Parapneumonic effusions. Now, sometimes parapneumonic effusions can be very small. Very small. Very small. But if they are slightly bigger, detail but if the pleural effusion is bigger, you need to always aspirate it and see. I think that is a consultant-led decision. But there is a strict criteria based on the size of the effusion. What I'm trying to highlight here is when you get a parapneumonic effusion, if it's big enough, you have to always aspirate it and see. Why are you aspirating it? Because it might be an empyema. Empyema එකක් වෙන්න පුළුවන්. Empyema එකක්. And මේක ලියාගන්න. What are the features of an empyema? කියන එක ලියාගන්න, very important. So features of an empyema, they occur as a complication of pneumonia, where there is infection in the pleural space. Infection in the pleural space is empyema. Infection inside the pleural space. Inside the pleural space. Now remember, these empyemas are often loculated. Loculated කියන්නේ pus pocket වගේ තියෙන. හරි? There are pockets of pus in sort of loculations. Loculation is like a wall එකක් තියෙනවා, මැද pus තියෙනවා. Right? So that is how it works. Loculation. And the pleura around it is thickened. So even looking at a ultrasound scan, right? When you see a empyema, the best way to look at it is actually an ultrasound scan. When you look at the ultrasound scan, you will see loculations and thickened pleura, thickened parietal pleura. Right. So these facts you need to know about empyema is very important, not only for MCQ, when you practice as well. Right. So empyema number 1 is a pleural effusion following as a complication of pneumonia. There is infection in the pleural space. The empyemas are often loculated and the pleura is thickened around the effusion. When you aspirate it, sometimes you can aspirate frank pus. Or when you culture it, there are organisms, right? Gram stain karapu gamang, culture karapu gamang, organisms are isolated. Right. And also, if you do a gas on it, if you take the pleural fluid and do a gas on it, the pH will be less than 7.2. That is a very important marker of an empyema. එතකොට ultrasound එකේ බලනවා, you can see the septation, thickened pleura. You take the sample out, immediately you can do a pH, and the pH will be less than 7.2, and the glucose level will be less than 60, because the organisms are using the glucose inside to multiply, and they create a very acidic environment inside. Their glucose is less than 60 and their pH is less than 7.2. Sometimes you can get frank pus also. That is pus. right? And also if you stain them and culture them, their gram stain will be positive, right? So that is how you recognize an empyema. That is how you recognize an empyema. The bedside ekema. If there is an empyema, you need to put a drain in. Anivaryeng, you need to put a drain in, right? Drain it out, right? Samala surgery කරලා time කරන්න වෙනවා. මොකද why? Sometimes they are so loculated, even if you drain in, you can't drain it out. එතකොට මේ open කරලා කඩ ඔය ටික අයින් කරන්න ඕනේ. සමහරවිට all the loculations in surgery you would have seen some of these abscesses you need to go in and break and take out pieces, right? So similarly, sometimes you have to open up the patient to take this out, right? So drain is the treatment there. So that's about empyema. Empyema, very important story. So in this patient who has a pneumonia, then hondai, right? Then hondai, and then again fever and a effusion. So most likely this is an empyema. So what do you have to do? Immediately you need to do මොකද්ද කරන්න ඕනේ? What is the next appropriate investigation? මෙතන දෙකක් තියෙනවා ඇත්තටම. Ultrasound and diagnostic pleural sampling. So මේ දෙකෙන් හොඳ මානසික you need to do a diagnostic pleural ultrasound එකේ you can see the changes, but it's not definitively. You have to take it and do a pH immediately. That is the way you diagnose. Because here we are suspecting an empyema, you need to do a diagnostic pleural fluid sample. Ultrasound එකේ you can see some things, but it is not the best thing to do. හොඳම දේ නෙවෙයි. හරි? හොඳම දේ නෙවෙයි. Kavin Gyalthina, does an empyema occur due to increased permeability at the site? It is probably that, plus the organism crossing the visceral pleura into the pleural space. Hari, it's an infection. It crosses the visceral pleura into the pleural space. So empyema ගැන අනිවාර්යෙන් දැනගන්න ඕනේ. Best response MCQ අහන්න පුළුවන්. නිකම්ම true false MCQ එකක් අහන්නත් පුළුවන්. Right. So that is about pneumonia. Any questions up to now? Oh, what is the pace for streptokinase in empyema? Streptokinase කරන්නේ, that is when I told sometimes the loculations are very tight and thick. Even if you put a tube in, you can't drain it out. So sometimes you either you can put streptokinase through the tube, or you can open up and put streptokinase. It basically dissolves all the septations. I got a කැඩෙන ඔක්කොම and වතුර වගේ වෙනවා, so it comes out.
So, 10 millimeter size එක අරගන්නේ මොකෙන්ද sir? Is it from the X-ray or the ultrasound? The 10 less than 10 millimeter.
Ultrasound එකේ. ඒක sorry, මම X-ray එකේ කිව්වා ultrasound එකේ. Right?
Since the ultrasound scan is not done here, sir, the next the investigation shouldn't it be the ultrasound scan? Since we don't know the size of
මෙහෙමනේ වැඩේ තියෙන්නේ here you are strongly suspecting වන්නෝ. මොකද කතන්දරේ හරිනේ. Patient හොඳ වෙලා දැන් ආයි වැඩි වුණානේ. තේරෙනවද? So here there is a very strong suspicion of a empyema. So you can't definitively diagnose empyema from an ultrasound. හරි මේක කොහොම වුණත් අපි aspirate කරනවා. තේරෙනවද? මේක ultrasound එකේ typical features නොතිබුණත් you would still aspirate this because the history is very suggestive නේ. ලෙඩාට හොඳ වෙලා දැන් ආයි මේක වැඩි වෙලා and there is now a new effusion. That is why. So Geet, LDH, yes, LDH will be high in the pleural fluid, but it won't be diagnostic of an empyema. Right? Diagnostic නෑ. pH එක තමයි diagnostic කොතන. pH එක, that's the most important value that you are looking for. Pleural fluid pH less than 7.2. Okay, right. Now, moving on to lung abscess. So lung abscess, typically in the X-ray, you will be able to see this nice cavity with a fluid level. We have done the X-rays and all before your OSCEs, X-rays. So you can hear thick walled abscess with a, so cavity with a fluid level is what you see. In this table, I have given you the causes of lung abscess. Causes. Now, obviously, refer that. But the important thing to remember is a lung abscess is a mix of organisms. Ek organism making lung abscess එකක් හැදෙන්නේ කලාතුරකින්, right? Lung abscess, you will find a mix of organisms. Mix එකක්. And these organisms are aerobic organisms and anaerobic. There's a mix of aerobic organisms and anaerobic organisms. So please write that down. So as I told you, make a pseudomonas infection again vitarak hadenne neveyi, it's a mix most often, right? Mix. Especially in Sri Lanka, it is a mix, right? Definitely. Right? If you take the fluid out and culture it, you will definitely get a mixed growth. Right? Ek organism එකක් එන්නේ නැහැ. Right. Okay. Right. Lung abscess due to recurrent aspiration is commonest in the posterior segment of the upper lobes. ඒක anatomy. Right? ඒක anatomy. ඒක මම කියන්නේ නැහැ. Okay. Now the important මේක පොඩ්ඩක් මතක තියාගන්න. මේක බොහොම වැදගත් මේ point එක. Right. Multiple lung abscesses can occur in intravenous drug use. අපි මේ කලින් කතා කරලා තියෙනවා. හරි intravenous drug users ලගේ lung abscesses එන එක ගැන. මතකයිනේ කතාව. So intravenous drug users get endocarditis of the right heart, and that causes septic embolization into the lungs. So multiple lung abscesses can occur in intravenous drug users. Staph aureus. So this is one of the rare instances where lung abscesses are due to one organism, and that is Staph aureus. තවයි ලංකාවේ අපි lung abscesses දකින්න එකක් තමයි මේ alcoholics ලගේ amoebic lung abscesses වෙනවා සමහර වෙලාවට. Amoebic. ඒක ගැන පොඩ්ඩක් එතන ලියා ගන්න. So usually it is a mix of aerobic and anaerobic, but one of the things that cause a single organism lung abscess can be endocarditis related to Staph aureus in IV drug users. The other fellow is MECA. Amoebic lung abscesses. Liver abscesses ennat puluwan, lung abscesses ennat puluwan, amoeba වලට. Amoeba is seen when you drink sort of illicit alcohol, kasippu වල එහෙම ඉන්නවා. So in alcoholics, that is something you can see. And the typical appearance of the pus in an amoebic abscess is like good apple sauce. මේ මොනවාද දියුල් කිරි වගේ දුමුරු පාටක් එන්නේ. තද දුමුරු පාටක් එන්නේ. Now, remember, when I make a boom point, in lung abscesses, the walls are usually thick, right? Walls are thick. Right? Make a man put a sambandha karana. Somebody asked the question also, cavity and lung abscess, is it the same? No, it's not. Right? This same thing can be applied to cavities also. Right? So if you have a thick wall cavity, it is an infection. Thick wall cavity is an infection. If it is a thin walled cavity, it can be things like granulomatous. Rheumatological disease. Table table. Thin walled abscesses rheumatological conditions. That is useful. Thick wall cavities and thick wall lung abscesses, infection. The wall of the lung abscess, as you can see in this X-ray also, is thick wall. Thick wall. Thick wall. So that is an important point. Now the final MCQ, last one, is that because in a lung abscess, the organisms are various types of organisms. It's very difficult to treat. Very difficult. You often need multiple antibiotics, long course antibiotics. And why it's so difficult to treat is because the organisms are mixed. The other reason why it's so difficult to treat is lung abscess antibiotic yanne ne. You can see this nice thick walled structure. It's very difficult to push the antibiotic into the lung abscess. Right? That is another reason why the treatment does not work. So, two reasons why it's very difficult to treat. One, because the mixed organism, right? And two, because of the difficulty in antibiotic penetration into the abscess. Samahara api meka sati haya ata treat karnawa lung abscesses. If you go to Valisara Chest Hospital, we see patients, rows and rows of patients on 6 weeks, 8 weeks treatment for lung abscess, antibiotics. Right? Okay. Right. Any questions?
Sir, single organism lung abscess work area ගන්න පුළුවන්?
Sorry, I forgot to mention that. Yes. Thank you for reminding me. So multiple lung abscesses can also occur in Burke-Hold area pseudomalae, melioidosis. That is another fellow that causes multiple lung abscesses. Yes, that's right. Right. Okay, right. So next we go on to bronchiectasis. Now you might argue a bronchiectasis can infection So what is bronchiectasis? Bronchiectasis is permanent and sort of irreversible dilatation of the air passages proximal to the terminal bronchioles. Now on Thursday we talked about emphysema, which the problem is distal to the terminal bronchioles. Here it is proximal to the terminal bronchioles. Proximal. And you can see in this CT scan, bronchial dilatation. Right. ඔන්න ඊතලේ ගහලා තියෙන එකට කියන්නේ signet ring appearance කියලා. මේ මුද්දක් වගේ නේද පේනවද මෙතන මේ මුද්දේ නිකන් මුතු මොකද අර දාන මේ ජුවල් එක වගේ මේක නිකන් signet ring appearance කියලා ඔකට කියන්නේ. And you can see the dilated Anushka iconic මට තේරෙනවා අහන්නේ empyema and lung abscess ඉතින් වෙනස් නේද lung abscess එකේ x-ray එකෙන්ම වෙන් කර ගන්න පුළුවන්. x-ray lung abscess is x-ray diagnosis. But empyema, you need to aspirate the fluid. It's a pleural effusion. The ultrasound scan might give you an idea of what exactly it is, but it's just a pleural effusion. But lung abscess can be diagnosed on the X-ray. Right. Any questions, Tava? So bronchiectasis is irreversible dilatation of the air passages proximal to the terminal bronchioles. That is what it means. Right. Now we go to the causes of bronchiectasis. MCQ අහන්න පුළුවන්. ඒව තමයි මේ කියන්නේ. Causes of bronchiectasis. Now here I have given you important causes of bronchiectasis. Hari. And remember, bronchiectasis is a cycle. Infection. The problem with bronchiectasis is it is a cycle of infection and destruction. Infection and destruction. Now, if you take causes of bronchial obstruction, right, it can be due to long-standing bronchial obstruction. Long-standing bronchial obstruction. Another cause is immunodeficiency. Very important. Remember, this is humoral immunity. Antibody deficiencies. You see bronchiectasis quite often. Immunoglobulin, antibody deficiency. Please write that down. Bronchiectasis is a common complication we see in these patients. Also, when there is a disease that causes problems in abnormal secretion clearance, like cartilaginous syndrome, cystic fibrosis, young syndrome, cartilaginous, cystic fibrosis, abnormal secretion clearance, bronchiectasis. And also, childhood prior infections like pertussis, measles, right? And also certain other things like fungal infections, NTM and non-tuberculous mycobacteria, TB, we know that's a common leading cause of bronchiectasis in Sri Lanka. So infection-related bronchiectasis. So these are some of the important sort of MCQ causes of things. And when make a boom, the areas that are involved is sort of different in these various types of bronchiectasis. The most important two that we see in MCQs are maker. Non-tuberculous mycobacterial infection commonly affects the right middle zone of the lung. And ABPA, allergic bronchopulmonary aspergillosis, which actually more causes obstructive sort of bronchiectasis. That's more central, around the hilum, more central. These are more localized causes of bronchiectasis. We long case bronchiectasis karla තියෙනවා. Hari. True or false regarding bronchiectasis? Bronchiectasis due to non-tubercular mycobacteria typically involves upper lobes නෙමෙයි right middle lobe කියලා අපි මේ දැන් කියලා කටගත්ත විතරයි. හරි. Presence of Pseudomonas in sputum indicates a poor prognosis. Yes. So ප්‍රශ්නේ තමයි මේ ලෙඩ්ඩු bronchiectasis ලෙඩ්ඩු get, as I told you before, chronic lung disease anyway they have a higher risk of pseudomonal infection. The problem is these people with bronchiectasis who have this recurrent bronchiectasis there's a lot of sputum and muck and jarava recurrent infections and there are colonized bacteria infections. So Pseudomonas is a major problem. Pseudomonas is a major problem. Right. Airflow obstruction is a common feature. Yes, that is also something that we see. Obstructive airway component bronchiectasis. So, inhalers sputum culture is essential for diagnosis. The bronchiectasis diagnosed from the clinical history, right? They have cough and phlegm and a copious amount of sputum. Long case, and it is radiologically. You diagnose bronchiectasis on radiology. Samhara velabata, where localized bronchiectasis, we examine through bronchoscopy, but that's not very common. Bronchiectasis, the gold standard of diagnosis is CT scan, right? Sputum culture diagnosis. Infection, you have to obviously do a sputum culture when there's infection. But diagnosis, it doesn't have much of a bearing on the diagnosis. Right. Now, I told you that the management of bronchiectasis, the problem with bronchiectasis is there is a lot of muck or jarava in the bronchial tree. Right. The bacteria go and live there now. Bacteria, things like Pseudomonas, nasty fellows like Pseudomonas. And they recurrently cause infection. Right. More infection, more the bronchial damage. Damage. The bronchiectasis gets worse. So this is just to remind you of the fact that bronchiectasis is a cycle, a vicious cycle of infection and airway destruction, right? Infection, airway destruction, infection, airway destruction. Vicious cycle. Okay. So management try to treat the underlying cause. Important thing is sputum clearance. Long case sputum clears. Postural sputum drainage becomes an important component in the management. Things like carbocystine to clear off the secretions is important. Carbocystine. If there are infections, you need to treat the infections quite aggressively. If patients have Pseudomonas, eradicate the Pseudomonas. They have a better outcome if you do that. And some people who have recurrent infections, we give prophylactic antibiotics. There we give azithromycin as the prophylactic antibiotic usually. Azithromycin. So මේ ඔක්කොම long case එකෙත් ඔයගොල්ලන්ට කියලා දෙන්නේ notes බලා ගන්න දැන්. තව very කල්යනා විභාගෙට 11th නේ පටන් ගන්න. So make sure that you cover all these areas properly. Okay. So azithromycin is used in some people, not in everybody, but some people to when they have recurrent recurrent bronchiectasis infective exacerbations. Okay, any questions? Right. Okay. So you sometimes use nebulized antibiotics for severe bronchiectasis. Nebulized antibiotics. ඒක තමයි මෙතන මේ අන්තිම ස්ටේට්මන්ට් එකනේ. Sorry. Okay. So Sarangani is how is the area affected TB? So TB bronchiectasis Sarangani is mostly upper lobes, right? TB bronchiectasis is mostly upper lobes. Okay, right. Now we go on to tuberculosis, right? Now again, TB is an important topic that you need to study for MCQ, SCQ. Even in short cases, long cases, in relevant places, you can be asked about tuberculosis. Ne? So it's an important topic. You can't not study it. Ne? Diabetes wage make a padang karanna one ekak. Right. Now this rather complicating looking flow chart. It's not really complicated. Oops. Sorry. Right. It just gives you the various stages in the natural history of tuberculosis. So essentially, the very first ever TB that you get is primary tuberculosis. Primary tuberculosis. In primary tuberculosis, you get hilar lymphadenopathy and this Ghon's focus. Usually peripheral lower zone. Both together, you call this the Ghon's complex. Primary tuberculosis. Now, in most people, primary tuberculosis heals by fibrosis and walls of this bacteria, as you know. In some people, you can get, if they are immunocompromised, various severe infection, right? Miliary TB, progressive lung disease, right? So that is in people who don't have a good immune system, they get progressive lung disease, or they can have severe bacteremia and miliary TB. Okay. Now, secondary tuberculosis, either you have reinfection with TB later on in life, or you have reactivation of the TB in the lungs. And you can have TB, when you get primary TB, podi bacterial seeding so you can get lung reactivation or reactivation in the other places, right? Later in life. So this is just a basic concept that you know, ne? Primary TB and secondary TB, main differences. Okay. So let's talk about the first MCQ here, primary TB. Primary TB presents with a prolonged febrile illness in the majority. Prolonged febrile illness in the majority. Make a godak lama. If you look at this primary TB is most often actually asymptomatic, probably. Some people get a short sort of febrile illness, but which is sometimes indistinguishable from a viral or bacterial podi mild infection. But I think most of it is asymptomatic, especially in Sri Lanka. Primary TB is mostly asymptomatic. Everybody gets primary TB at birth. So, asymptomatic. Sometimes you see three things to remember. A small pleural effusion, right? Small pleural effusion. Sorry, yeah. So this mama table right? So sometimes you get a small pleural effusion. Right? And also this unusual sort of nodular conjunctivitis called phyllectenular conjunctivitis. Nodular conjunctivitis pleural effusion primary TB, and some people get erythema nodosum. Somehow, right? Erythema nodosum, pleural effusion. And if you take the regional lymph nodes, you might be able to see a bit of caseation, but nothing beyond that. Poddak regional lymph nodes, well, caseation එකක් තියෙන්න පුළුවන්. හරි? Right. So remember, it just causes this lymph node involvement. So in the hilar nodes, and also this Ghon's focus. Again, you can see granuloma, bit of caseation in that area only. හැමතැනම නෙවෙයි. හරි? Mild එකක් එන්නේ. Little bit of caseation in the hilar nodes and in the Ghon's focus. Hi. Okay, so this table again emphasizes the differences between primary and post-primary or secondary TB. Okay? So remember, asymptomatic, Ghon's focus, Ghon's complex, little bit of caseation, granuloma in these areas. There can be complications of primary TB if there is immunocompromised nature. But some people get this sort of immunocompromised phenomena, polypleural effusion, erythema nodosum, and this phyllectenular conjunctivitis. Hari. Okay, right. So that is all you need to know about primary TB. Right. Any questions up to now? Hari. Sajid, scrofull derma kiyane Sajid? That is because of sort of, it's a skin change because of the sort of spread of caseation. Hari? It's often you see it over a affected lymph node. Your skin in a change එකක් අර මේ caseation එක නිකන් එකයි TB එකයි spreads into the skin, ruptures the lymph node and spreads into the skin. That's what usually happens in scrofull derma. Hari. Okay, so okay, right. Hari, right. Okay, now we go on to now we go on to TB. Here we are focusing on secondary TB or post-primary TB. Secondary TB or post-primary TB. Primary TB ගැන ඉච්චර වැදගත්කමක් නැහැ. අපි දැන් ඕක කරපු ටික දැනගත්තම ඇති. Right. How do you diagnose secondary or post-primary TB? This state MCQ gives you a good set of information on that. So let's go through this. Negative Mann to test excludes the diagnosis. Negative Mann to test excludes the diagnosis. Right. Hari. Then Mara Vedini me. Mann to test is not a test for active TB. Remember that. Mann to test is not a test for active TB. When you have built up immunity against TB, just tests immunity against TB. That's the only thing it tests. It does just test immune response against TB. Right? Mann to a tuberculin test just tests the immunity against TB. That's right. Right. Immunity against TB. So it is not a diagnostic test for TB. So negative Mann test does not exclude the diagnosis. Does not exclude the diagnosis. Right. Okay. Right. Does not exclude the diagnosis. Actually, a Mann to test can be negative in full-blown TB if you're immunocompromised, because it just tests the immune response. Right? So, in a patient with HIV/AIDS who has TB, the Mann will be absolutely negative. But they're full-blown TB, right? Because their Mann test does not become positive because they don't have immune system, right? So remember, Mann test just tests the immune response against tuberculosis, nothing else, right? Higher yield of sputum TB is noted in patients with HIV. Right? So the HIV patients have overwhelming tuberculosis, right, which is not controlled by their immune system. So obviously they have a higher bacterial yield. Hari? Okay. Right. Now, another way of, so how do you diagnose? The gold standards of diagnosing tuberculosis are sputum, AFB, and culture. Okay? Now, if you take culture for tuberculosis, the culture, there are various types of cultures. The classical culture, microbiologist culture, which is called the LJ medium, Lowenstein-Jensen medium. Eka culture takes about 4 to 6 weeks, right? The Lowenstein-Jensen culture medium to culture takes about 4 to 6 weeks. Right? But remember that there are newer liquid cultures which have a quicker turnaround time. Liquid-based cultures, you know that can come back in about 2 weeks, right? Maximum 2 weeks. Liquid cultures. So up to now we have been using sputum AFB. Sputum AFB is very quick. Cultures take longer, but the liquid cultures 2 weeks. Lowenstein-Jensen takes about 4 to 6 weeks. Now we have a better test at our arsenal or in our diagnostic box, which is the gene expert, which is a PCR-based technique, which you can diagnose TB, and also it tests for drug-resistant genes in the organism. Right? So it tests for isoniazid and rifampicin-resistant genes also, which is an added advantage. So gene expert test for Mycobacterial TB is useful for assessment of drug as well as for diagnosis. Right. Now in your short cases, somebody asking, sorry, ma'am, how the me Pratibhat prashnayak kahala tiyena. Mokada Pratibhat ahanne wait. Primary TB MAN2 එකට මොකද වෙන්නේ? ගොඩක් වෙලාවට negative because there is not enough time to manifest the immune system. මම ඇත්තට මේ ප්‍රශ්නේ පොඩි අඩුවක් තියෙනවා. මේක ඇත්තට මට ඕනුනේ cause a pleural effusion in positive MAN test in a patient with HIV කියන එක තමයි මට ඕනුනේ මෙතන. But even in primary TB, the MAN2 can be still negative because if you do it early on, still there is not enough time for the immune response to manifest. A statement a product is there a role of doing full blood count? So in TB, and that's an important question. TB full blood count is normal, but at least initially in infant you see a neutrophil. Neutrophilia එකක් එනවා. ඒක ලියා ගන්න පොයින්ට් එක MCQ වලට අහන්නත් පුළුවන් දෙයක්. In initial early stage tuberculosis you can get a bit of a neutrophilic full blood count. ඊට පස්සේ ඒක නැති වෙලා යනවා. හරි. Now in your short cases we talked about pleural effusions in tuberculosis. අපි කතා කරා pleural effusions in tuberculosis. ගැන කතා කරා and I told you what are the characteristics like ලියා ගන්න pleural effusions in TB ගැන පොඩි note එකක් පොඩ්ඩක් ඉන්න හරි pleural effusion in TB. So pleural effusion in TB is regarded as an extra pulmonary manifestation. පළවෙනි දේ. ඒක extra pulmonary manifestation එකක්. Extra pulmonary manifestation. හරි. Okay. Second, if you aspirate a pleural effusion, TB pleural effusion, important things you will see. Number one are a lymphocytosis, and a high ADA level. Okay. Last point to remember. So exudate lymphocyte high ADA. Exudate lymphocyte high ADA. Okay. So if you have an exudated lymphocytic high ADA effusion, you have a 95% sensitivity specificity in diagnosing pleural tuberculosis. Exudative lymphocytic high ADA. You have a 95% probability that this is TB, sensitivity specificity. Additionally, if you can do a pleural biopsy and that is positive granuloma, okay, pleural biopsy, that is almost diagnostic, 99% sensitivity specificity. So exudate lymphocyte, high ADA and pleural biopsy showing granuloma, that is almost 100% diagnostic of TB. ඇයි මං එහෙම කියන්නේ අන්තිම කාරණේ ලියා ගන්න. It is very, very difficult and unusual to isolate organisms from pleural fluid. It is very unusual and rare to isolate organisms from pleural fluid. එක මතක තියාගන්න. So these are all sort of diagnostic tests ගැන මේ කතා කරන්නේ. Interferon gamma release assays are useful to diagnose TB in endemic areas, active TB endemic. So interferon gamma is just a glorified Mantoux test, right? It again tests the immune response to tuberculosis, right? Interferon gamma is my main immune cytokine in tuberculosis. This is just it is useless in endemic areas. Positive non-endemic area ටිකක් useful. But remember, both the Mantoux and the IGRA, interferon gamma release assay, just checks the response to TB, just checks the past infection. Past infection, nothing else. Past infection. Okay. Right. All of this I have talked about. හරි තව මේ line probe assay කියලා එකක් ටිකක් special PCR molecular method එකක්. So in this PCR or the gene expert, you can measure or it checks the genetic elements of rifampicin resistance. Right. Make a okay. Now, this all of you have seen. Okay, Kavindi, AD is better than a TB pleural. Yes, yes, Kavindi. So, culture is often negative in pleural fluid. ADA is better in diagnosing TB pleural infection than culture. Yes. So, ADA, so as I told you, ADA, lymphocytic exudative plus pleural biopsy, 99%. Very unusual for a culture to be positive in pleural fluid. Very unusual. Right. හරි. එතන මේක බලන්න නේ TB treatment. මෙන්න මේ table එක ඔලුවට දාගන්න චුට්ටක්. හරි. මේක පොඩ්ඩක් because so okay අර categories දෙකක් තියෙනවා කියලා ඔයගොල්ලෝ දන්නවනේ TB treatment categories. So pulmonary, extra pulmonary, new TB එක අපි new category. ඉස්සරහ category 1 කියලා කියනවා. ඒකට දැන් new කියලා කියනවා. So this is the treatment schedule. Isoniazid, rifampicin, pyrazinamide, ethambutol, 2 months, and then 4 months of isoniazid, rifampicin. So this is the so-called category 2 or retreatment category. If you have a relapse, treatment, failure, loss to follow up, they fall into the retreatment category. And the treatment schedule is different. It is an 8-month treatment course. And that might be longer, but this is a 8-month treatment course. So different කතාවක් තියෙනවා. Now, in this table, I have given you the important features of the medication, right? Anti-TB medication: isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. Right? මේ table එක බොහොම වැදගත්. I'm not going to read through this table. දැන් ඔයගොල්ලෝ මේවා අහලා තියෙනවා, දැකලා තියෙනවා, පුරුදුයි. මේවා MCQ වලට අහනවා අනිවාර්යෙන්. Sure and sure. No doubt. මේ table එකේ තියෙන කාරණා are very important about these drugs. Unfortunately, pharmacology is a lot of remembering things, facts. But ඉතින් කරන්න දෙයක් නැහැ. That is important. like pharmacology නැතුව practice කරන්න බැහැනේ. So these important things. Isoniazid මන්නේ ඔයගොල්ලෝ කතා කරන්න මේක side effect ටික බලා ගන්නලා මේක තමයි වැඩිපුරම අපි අහන්න කැමති ඔයගොල්ලෝ. So isoniazid, these side effects, peripheral neuropathy is a very important side effect නේ. You can get drug induced lupus වගේ features එන්න පුළුවන්, right? ඔය rash වෙන ගොඩක් බලමාලු කෑවම rash වෙනවා මේ isoniazid වලට. හරි? Okay. Rifampicin, all of you know, it is a major drug inducer නේ. enzyme inducer එකක් rifampicin කියන්නේ. And also අර මොකද්ද pink body fluid pink වෙන කතාවනේ fanta වගේ වෙනවා කියලා. මම හිතන්නේ chams තමයි තාම මේ lecture කරන්නේ අපි ඉගෙන ගන්න කාලෙත් ඔය කතන්දරේ කියලා. ඉතින් අපි Rifampicin you will not forget. Ethambutol, the main problem is the optic neuritis, and you don't use it in children because of that fact. So remember, any of these drugs have a potential to cause hepatotoxicity, especially isoniazid, rifampicin, pyrazinamide. Ethambutol එච්චරම නෑ, but එන්න බැරි කමකුත් නැහැ. Isoniazid, rifampicin definitely hepatotoxicity. Pyrazinamide, sorry, streptomycin is like gentamicin, so renal toxicity and ototoxicity are the problems there. Just absorb this table a little bit. It's very, very important. Again, I emphasize, විභාගයට යන්න කලින් මේ slide ටික බලාගෙන ගියා නම් ඇති. හරි. You will definitely pass the MCQ at least. You will pass very well. කොහොම මම මෙතන දාලා තියෙන මේ slide වලට ඔය අහන ಜಾති important ඒවා ටික තමයි. මේ විදිහ හංගන් ඉඳලා වැඩක් නැහැ නේ බං. ඉතින් ඕක ඉතින් අපි අහන ප්‍රශ්න ටික. ඉතින් අපි උඹලට කලින් ගන්නලා යවනවා. ඉතින් ඕක මහලු ප්‍රශ්නයක් නෙවෙයි. It doesn't define, obviously there are varying opinions on this sort of thing, but උඹලා විභාගේ පාස් වෙලා merit list එක උඩට ආවම ඉතින් that sets you for life. හරි. Okay. විභාගෙට ප්‍රශ්න කියන්නේ නැහැ. ඒක නම් කවදාකවත් කියන්නේ නැහැ. But මේවා තමයි මේ වගේ තමයි අහන්නේ කියන්නේ. So Chamali is hepatotoxic reversible, or can it progress to chronic hepatitis? Chamali, both are possible. Reversible වෙන්නත් පුළුවන්. සමහර types seen people who progress to chronic hepatitis also. Right? Most of them reverse back to normal. Hari. TB treatment ගැන MCQ එක බලමු ඊට. True or false regarding treatment for pulmonary TB is treated with a 9-month regimen in most cases. 9-month regimen. වැරදිනේ බයිලා කතන්දරයක්. It is a 6-month. Most often it is 6 months for new cases. Right? ඔය සමහර වෙලාවට CNS TB ටිකක් ඊට වැඩිය ට්‍රීට් කරනවා, but ඒකත් ටිකක් අමුතුයි. ඒක ට්‍රීට් කරන මිනිස්සුන්ව වෙනස් වෙනවා ටිකක්. හරි? But definitely new pulmonary TB 6 months. Right. Isoniazid causes peripheral neuropathy අපි ඉගෙන ගත්තා. ඒක හරි. Pyrazinamide causes optic neuritis should be ඒක බොරු කතාවක්. ethambutol වලට තමයි. ethambutol වලට. Rifampicin we know is a very, very important enzyme inducing drug and should be avoided in HIV patients. මොකද? It interacts with all the HIV related drugs. So okay, වෙන alternate drugs තියෙනවා. ඔය rifampicin වෙනුවට HIV වල පාවිච්චි කරන. There are alternate medications which we use. Hearing loss is a recognized adverse effect of streptomycin is absolutely right. ඒක gentamicin වගේ renal and ototoxicity or hearing loss is a main side effect. Hari. Any questions? So මෙන්න මේ table එක මෙතන මේ mechanisms උත් තියෙනවා. ඒව වැඩි අහන්නේ නැහැ. මොකද අපිටවත් ওই mechanisms මතක නැහැ. මේක pharmacology paper එකක් නෙවෙයිනේ. හරිද? pharmacology paper එකක් නෙවෙයි නිසා වැඩි mechanisms අහන්නේ නැහැ. ඒක අපිටත් වැඩි මතක නැහැ. But as a clinician, we will know all the side effects and narakameka, so we will make an MCQ on it. Side effects and important therapeutic considerations.
Sir, me vertebral TB වගේව අපි ගන්නේ extra pulmonary කියලාද නැත්නම් CNS වගේ කියලාද?
Vertebral TB is extra pulmonary. CNS TB කියන්නේ meningitis, brain එකේ tuberculomas, very rare you can get encephalitis නේ. ඒ වගේ එක ඒවා තමයි CNS TB. Spinal cord එකේ involvement එකක් ආවොත් තමයි CNS වෙන්නේ. හරි? And that's very difficult to treat. The other problem with CNS TB, especially this, ethambutol is not very effective there because it has low levels in CSF. Pyrazinamide is better for that. හරි මේ CSF penetration එක හොඳයි. streptomycin වල CSF penetration එක හොඳයි. ethambutol වල එච්චරම හොඳ නැහැ.
ඒකට අර කට්ටියටද එතකොට මේ 6 months මන් දෙන්නේ එතකොට
මොන කට්ටියද?
extra pulmonary කට්ටියද?
extra pulmonary yes 6 months වලට තමයි ගොඩක් අය treat කරන්නේ. හැබැයි ඔය මේ CNS TB vertebral TB some people treat for longer. හරි 9 months වලට treat කරන අයත් ඉන්නවා. සමහර අවුරුද්දක් දෙන අයත් ඉන්නවා. Drug resistant TB is a whole different ball game that is longer. සමහරලාට 9 months 12 months වගේ treat කරන drug resistant ඒවා. But standard pulmonary extra pulmonary TB 6 months, right? exception might be CNS TB and drug resistant TB if we treat for long. And also this retreatment category 2 අපි කොහොමවත් පරිපූර්ණ treat කරනවනේ. category 2 එක අපි සාමාන්‍යයෙන් මාස 8ක් treat කරනවා. ඕ ඊට මාස 10ක් වෙන වෙලාවලුත් තියෙනවා ඒක.
So one more thing sir මේ ඒකේ category 1 වල ඒව විතරද අපි first line කියලා ගන්න 1 or 2 දෙකම first line drugs කියලා ගන්නවා.
ඔක්කොම first line drugs තමයි. කියන්නේ මේ first line drugs පහයි තියෙන්නේ. මේ පහ. හරි? එතකොට තව තියෙනවා ගොඩාක් anti TB drugs ඒවා second line. ඒවා ගොඩක් අර පාවිච්චි කරන්නේ drug resistant TB වලට තමයි. ඔය එක fluoroquinolones අනම්මනම් තියෙනවා. those are mostly used for drug resistant TB. drug resistant TB ට සරව මාතෘකාවක් ඒක ඔයගොල්ලෝ අහන්නේ it's a very specialist area. හරි. අපි හරියට ඒක දන්නේ නැහැ. it's a very specialist respiratory වලත් specialist area එකක් අපි කවදාකවත් treat කරන්න යන්නේ නැහැ. As a general physician we would never treat drug resistant TB. හරි never. මේ TB වලත් අපි treat කරන්නේ නැහැ without getting opinions because it's a very specialist area and should be carefully treated. නේ නැත්නම් you get resistance and various other nonsense complications. හරි. So ඉතින් ඔයගොල්ලෝගේ කියනවත් අහන්නේ නැහැ ඒවා. ඒ නිසා බය වෙන්න එපා. True or false regarding treatment of TB, patient should be isolated until sputum for AFB becomes negative. එහෙම එකක් තියෙනවද? That is a concept which has gone out of fashion. හරිද? ඒ දවස්වල නම් ඕක තිබුණා. දැන් නම් එහෙම කරන්නේ නැහැ. But සාමාන්‍ය infectivity එක වැඩි treatment පටන් ගන්න maybe 1 to 2 weeks ඇතුළත තමයි treatment මේක වැඩි. හරි 1 to 2 weeks අතර spread එක වැඩි. Intensive phase is just for 2 months, not for 4 months. Right. Isoniazid is given to contacts. හරි. මේ මම මෙතන පොඩ්ඩක් දීලා තියෙනවා මේ drug resistant TB වලට. වත් මේ අමුතු drugs kanamycin, levofloxacin මම නිකන් ඔයගොල්ලෝ බලන්න මේ දාලා තියෙන්නේ. හරි. මාස 8 මාස 12 වැඩිපුර දෙනවා කියලා. හරි. right. මෙතන තියෙනවා කාටද අපි prophylactic anti TB දෙන්න කියන එක. මේ වගුවේ තියෙනවා. හරිද? Who should be given prophylactic treatment කියන. මෙන්න මේක බලන්න. හරි. ඒක කියවන්නකො ඉස්සෙල්ලා. PL HIV කියන්නේ patients living with HIV. හරි? You don't have to admit newly diagnosed patient with TB. ලංකාවේ ඔක කරා. ඒවා අනිවාර්ය නෑ. හැබැයි ඉතින් පොඩ්ඩක් if the patient is not very trustworthy අරක වගේ you can send them off. මිලියරි TB වලත් සමහර වෙලාවට ටිකක් වැඩිපුර treat කරනවා. ඒකත් depending on the clinical situation. හරි miliary TB also sometimes 1 year වලට treat කරනවා. හරි. Okay. මෙන්න මේ හතරවෙනි MCQ පොඩ්ඩක් controversial TB meningitis usually more than 6 months අපි treat කරනවා ඒක. හරි. ඒක මතක තියාගන්න. හරි. මේ පස්වෙනි එකත් ඕනේ නැහැ MDR TB කියන ඔයගොල්ලන් අහන්නේ නැහැ. ඒක ඕනේ නැහැ. කරදර වෙන්න එපා. මෙන්න මේවා තමයි දෙන බේත් ටික ඕනනම් මතක තියාගන්න. නිකන් බලා ගන්න. Sorry, MDR TB world. Right. Now, the last thing I need to tell you, Lamai, is that sometimes we use steroids as adjunctive to anti-TB drugs. Yes, steroids, they are anti-TB drugs. When me pahe tamai api samanning eva denne TB meningitis definitely you would give and cord spinal TB with cord compression. And the idea is to reduce the inflammation around the neurological structures. Neurological structures වටේ spinal cord එක cranial nerves වටේ inflammation එක අඩු කරන්න තමයි ඒක දෙන්නේ. So this is where you use steroids on top of the anti-TB medication. So remember those two plus මේ අනිත් ඒවා තුන pericardial effect those are not very common. මේ laryngeal TB generally very common නෑ. But in the wards, you would have definitely seen TB meningitis, spinal TB with cord compression. ඒවට steroid අපි අනිවාර්යෙන් දෙනවා. Okay. අන්තිම එක මං හිතන්නේ. Yeah. අන්තිම එක. මේ කියවල ඇතිනේ ඔයගොල්ලෝ 28-year-old man. Any questions? ප්‍රශ්න තියෙනවද?
Sir, is it isoniazid for the prophylaxis, sir?
Isoniazid, yes. Isoniazid, yes.
සර් මේ 9 වෙනි එකේද isoniazid given to pentaxium sir ඒක ස්පෙસિෆික් විතරක්
Specific
දෙන්නේ.
clinical specific මේගොල්ලන්ට තමයි දෙන්නේ. Yes. හැමෝටම
ඒතර
දෙන්නේ.
මේ වගේ එකක් ආවොත් සර් අපි true කියලාද මාක් කරන්නේ නැත්නම් false ද?
ඒ ස්ටේට්මන්ට් එක ඇත්තට මගේ දාලා තියෙන එක ඇත්තට හරි නෑ නේද? ඒක උඩට ස්පෙસિෆික් දෙයි එක්සෑම් එකට දෙනකොට. කොහොමද උනකොට ඉතින් කියන්න බෑනේ නේ බං. ඒක හරි.
සර් අනිත් එක සර් මේ තාමත් අර සති දෙකේක සර් ලංකාවේ ප්‍රැක්ටිස් කරනවා නේද? අර මේ ළඟදි patient කෙනෙක් හිටියා. එයාට සති දෙකකින් රිපීට් ස්පියුටම් එක කරනකම් isolate line එක කියලා.
ඔව් ඒක හරි. ඒක හැබැයි outdated practice එකක් ඉතින්. හරිද? මම දන්නේ නැති ඒවා MCQ ට අහන එක නෑ. මම දැම්මට මම නිකන් ඒක දැම්මේ නිකන් ඒක කියන්න. ඒක outdated practice එකක් ඒක. මේ දැන් විශේෂයෙන්ම ඔව් එහෙම නිකන් එහෙම ගයිඩ්ලයින් වල කොහෙවත් කියවිලා නෑ එහෙම කරන්න කියලා.
Thank you sir.
Right. Now this question focuses on anti-TB drug-induced hepatitis. දැන් බලන්න patient is on rifampicin හතරම දෙනවා 4 weeks දැන් ගිහිල්ලා pre-treatment liver test normal but දැන් ඔන්න කන පැරෙන්න transaminases වැඩි වෙලා දැන් වාත වෙලා තියෙනවා. හරි. So this is common, very common. Drug-induced hepatitis. Drug-induced hepatitis. හරි. මොකද කරන්නේ? Obviously you have to stop everything. හරි ඔක්කොම නවත්තන්න ඕනේ. ඔක්කොම නවත්තන්න ඕනේ. හරි. සමහර අයගේ තුන අපි කරන්නේ ඔක නවත්තලා ඔක normal වෙනකන් ඉන්නවා. හරි. නවත්තලා ඔක normal වෙනකන් ඉන්නවා. හරි. නවත්තලා normal වෙනකන් ඉන්නවා. normal එකක් ඉඳලා ඊට පස්සේ එක ආයි දානවා. හරි? එක ආයි දානවා. ඒක දාන විදිය මේ තියෙනවා. එච්චර වැදගත් නෑ ඒක මතක තියාගන්න. හරි? එක reintroduce කරනවා චුට්ට. හරි. සමහර වෙලාවට in some cases you can't stop it completely. Right? That is a problem. එතකොට අපි කරනවා so there are two things now remember so anti-TB induced hepatitis outcome stop the drugs no doubt about that in most patients we wait until the transaminases normalize and reintroduce the anti-TB drugs one by one slowly one by one monitoring the liver function that is one එක විදියක් the other way is some patients have very severe disease. The special example in this is CNS TB. If you stop all the drugs for CNS TB, the patient is definitely going to die. So in those people, until the the liver functions normalize, you use something called bridging therapy. Bridging therapy. Bridging therapy කියලා එකක් පාවිච්චි කරනවා. ඒකට පාවිච්චි කරන drugs ටික තමයි මේ දීලා තියෙන්නේ. Bridging therapy, right? So that is in some, especially patients with CNS TB who develop hepatotoxicity. We don't stop. We stop the hatarama navattala bridging therapy ekata danawa leda. Bridging therapy ekata danawa until the liver functions normalize. ඊට පස්සේ අර ආයි අනිත් drugs ටික පටන් ගන්න පුළුවන් එක එක. Bridging therapy. ඒක මතක තියාගන්න. Hari. Right. So those are all the lung infections. ප්‍රශ්න තියෙනවද බලන්න? So today we did a lot of things. Pneumonia, various sort of clinical features, etiology, scoring systems for risk stratification, right? Then about pleural effusion, I'll talk about empyema in more detail because that's an important topic to know about. Lung abscesses, bronchiectasis, and tuberculosis. Tuberculosis anti-TB drugs can diagnosis again. Nitaram MCQ ahana. When to use steroids, that sort of thing is frequently asked, right? And this is a best response MCQ on what to do in drug-induced hepatitis. Actually, you know the
MCQ is spineless involved with TB. Duration of therapy is 9 months scale. So
ඒක කොයි කාලේ ආපු එකක්ද කියන්නකෝ මට.
there's $12 A-level.
ඔව්. ඕකේ හරි කන්වෙන්ෂන් එකක් නැහැ මෙයා. ඒකනේ ප්‍රශ්නේ. ඕකේ හරියටම මේක කොච්චර කාලයක්ද ට්‍රීට් කරනවා කියන එක මේ කොහෙවත් ලියවිලා නැහැ. සමහර අය මාස 9ක් දෙනවා, සමහර අය මාස 6ක් දෙනවා, සමහර අය අවුරුද්දක් දෙනවා. ඉතින් ඒක හරි අමාරුයි ඇත්තටම. මේවා කරන්න. ඒකක මේ රිසර්ච් උත් හරි අඩුයි, හරි වාත කේස් එකක් ඕක මේ. නියුරොලොජිස්ට්ලා එක විදිහකට ට්‍රීට් කරනවා, තව චෙස්ට් විෂය තව විදිහකට ට්‍රීට් කරනවා. ඉතින් ඒක ඇහුවොත් අසාධාරණයි කියලා මට හිතෙනවා මේ වගේ මේ ප්‍රශ්නේ ඇත්තට. මොන ප්‍රශ්න තියෙනවද? සාරංගනි, there's a little bit left. I have something to do now. Shall we do it on Tuesday?
Yes, sir. We have one more session for respiratory, right?
Yeah. Hari.
Hari.
Don't worry, we'll be able to finish before end of this month. Okay. Hari. මේ ඔයගොල්ලෝ මේක කරලානේ එන්නේ නේද before you come to this session? මේ නැත්තම් තේරුමක් නැහැ. Do the MCQs and come. Hari. So third one you have නේද? I sent you the presentations and the paper ne?
Yes, sir.
Hari. Okay. මම දැක්ක ඔයගොල්ලෝ ප්‍රශ්න වගේක් දාලා තිබුණා. Answer those today. ඔයගොල්ලෝ දාලා තිබු ප්‍රශ්න ටික. Hari ne? Hari. Okay. Bye.
Thank you.
Thank you,
Okay,
sir.
bye.
Thank you, sir.
Thank you, sir.
Thank you.